This executive briefing covers the FDA approval analysis of Rhapsido, which is Remibrutinib, an oral Bruton's tyrosine kinase, or BTK, inhibitor for chronic spontaneous urticaria, or CSU, refractory to H1 antihistamines. Rhapsido was approved on September 30, 2025, as a first-in-class oral BTK inhibitor for dermatologic use, addressing a gap for 1 to 2 million patients who fail antihistamines. A key differentiator is its rapid onset, with approximately 34% of patients achieving disease control by week 2. Rhapsido is a novel, small-molecule kinase inhibitor, marking the first entry of BTK inhibitors into non-malignant immunoinflammatory disease. It blocks intracellular BTK signaling, preventing histamine release. It is delivered as a 25 mg oral tablet, taken twice daily, for adults with antihistamine-refractory CSU. CSU presents a heavy burden, with 50% of patients failing antihistamines. An estimated 1 to 2 million patients are impacted in the USA, and the average disease duration is over 5 years, highlighting a clinical unmet need. Rhapsido's mechanism of action involves dual pathway blockade by inhibiting BTK, a central node in mast cell activation. It blocks both IgE-mediated and IgG-mediated pathways, halting the release of histamine from mast cells and basophils. The FDA indicates Rhapsido for treating chronic spontaneous urticaria in adults who remain symptomatic despite H1 antihistamine treatment. It is not indicated for other forms of urticaria, such as cold, heat, aquagenic, or vasculitis. The pivotal trials, REMIX-1 and REMIX-2, involved 925 adult CSU patients, 60% with severe disease. These were randomized, double-blind, placebo-controlled trials. Co-primary endpoints were changes in itch and hive scores at week 12. Disease control, defined as a UAS-7 score of 6 or less, was achieved in approximately 47 to 50% of Rhapsido patients in the REMIX trials by week 12. This compares to a 20 to 25% control rate with placebo and 60 to 75% for omalizumab, which is included for context. A competitive edge of Rhapsido is its rapid onset. Approximately 34% of patients achieve disease control by week 2, which is faster relief than current biologics, which typically achieve only about 5% disease control at week 2. In terms of adverse events, the most common reactions were nasopharyngitis at 11%, mucocutaneous bleeding at 9%, and headache at 7%. Importantly, 0 severe bleeding events were reported during the 24-week controlled period. The primary safety signal is bleeding, which occurred in 9% of patients versus 2% for placebo. This is a class effect of BTK inhibition impairing platelet aggregation. Patients must report any bruising or bleeding immediately, and caution is advised with concomitant antithrombotics. There is a safety alert regarding hepatic contraindication. Rhapsido is absolutely contraindicated in patients with any degree of hepatic impairment, including all child-PUE classes. Mandatory liver function testing is required before initiation, as the drug is extensively metabolized by the liver. The standard dose for Rhapsido is 25 mg orally, taken twice daily. The oral administration eliminates the burden of injections and enables primary care prescribing. Tablets can be taken with or without food, but should not be crushed or chewed. Due to the bleeding risk, treatment interruption is mandatory for surgeries. Interruption is generally 3 to 7 days preoperatively, with resumption 3 to 7 days postoperatively, depending on the procedure's bleeding risk. Comparing Rhapsido to competitors, it offers a fast onset at week 2 and a lower cost compared to omalizumab. However, its peak efficacy is around 50%, lower than omalizumab and cyclosporin. Key risks include bleeding and liver contraindication. In conclusion, Rhapsido is a cost-effective, new first-line biologic option for patients prioritizing speed and oral convenience. It is expected to capture 25 to 35% of the second-line market, offering speed and convenience for slightly lower peak efficacy. This concludes the video on the Rhapsido FDA approval review. We will now move to a discussion of the clinical implications. This final scene lists the image sources used throughout this video.